For the ultrasound scan of the wrist, we shall split it into two compartments, the palmar compartment and the dorsal compartment. We will evaluate the structures with the scanning planes targeted to the palmar compartment of the wrist. The most important thing to analyze is the median nerve. To locate this nerve with greater clarity and simplicity, it is convenient to perform a scan starting from the third distal of the forearm. In this way, we can easily establish the position of the median nerve. We can see very well that it is a rounded structure in the context of the muscles of the forearm. Once we have found the median nerve, we may move the transducer distally until we reach the wrist and, more specifically, the carpal tunnel. In this scan, we recognize the proximal portion of the carpal canal that is delimited by some very important bone components. On the right, we see the semilunar facet, which is determined by the surface of the tubercle of the scaphoid. On the other side, instead, we study a different bone structure, which is the surface of the bone. We can admire the canal, in which we can see, at a deeper level, the palmar surface of the semilunate bone. This is the proximal part of the carpal canal, where we first identify the most proximal portion of the flexor retinaculum, in which we see the median nerve. The median nerve has the typical characteristic of all nerves, and it is represented as a fascicular structure, whereas tendons normally have a fibrillar structure. It is very well displayed on the short axis scan, and we recognize this characteristic aspect of the peripheral nerve, in this case, the median nerve. We now move back into the canal, and we need to pay attention to the correct orientation of the ultrasound beam. This is because if the beam is not perpendicular to the nerve, then the nerve disappears and becomes hypoechoic, while, as you can see, if the beam is perpendicular, the structure reappears.
Ricompare nella sua struttura assolutamente in maniera precisa. Detto questo,
we recognize within the carpal canal, below the median nerve, the superficial and deep flexors of the fingers. If you invite the subject to move and flex his fingers, we see that these tendons move. As you can see, we have the opportunity to see the flexors of the fingers moving. The curious and important thing is that this flexion and extension of the fingers does not have the median nerve to move along with the flexures, but it moves sideways from the left to the right and vice versa. And this happens in normal conditions. The flexor retinaculum, which borders the carpal canal, in this region has a curved aspect, while more distally, the retinaculum is straighter and thicker, and this is an absolutely normal feature. After the scan, we can study the carpal canal with scans along its long axis to locate the longitudinal course of the median nerve. This scan allows us to identify the median nerve, which penetrates in the carpal canal and below which the tendons of the fingers run. Once again, if we ask the patient to move his fingers, we can see how the median nerve appears to be motionless with respect to the flexion and extension movements of the finger tendons. Another important scan is that one done to study the Guillaume's canal, in which, as we know, runs the ulnar nerve. We return to the main scanning of the volar side of the wrist, and we display our median nerve. In the most medial portion, we can perfectly recognize the ulnar artery. Close to the ulnar artery, we can see the ulnar nerve, inside Guillaume's canal. We now move to assess the dorsal region of the wrist. And also, from this part, we mainly perform transversal scans. These are better to study the tendinous compartments.
Anche qua faremo delle scansioni prevalentemente trasversali, che sono le scansioni migliori per studiare i compartimenti tendinei.
An important anatomical point is Lister's tubercle, which we see here as a deformation of the bone profile on the radial level. This is an important reference point because it allows us to count the number of compartments. Specifically, Lister's tubercle divides the second compartment from the third compartment of the extensors. So, if we start from the second extensor compartment and we count on the radial side, we reach the first compartment of the extensor tendon, which obviously contains two components. We can see the first compartment, the second, Lister's tubercle, the third compartment, fourth, fifth compartment, and finally the sixth, the last compartment, where, as you know, runs the sensor carpi ulnaris tendon. This anatomy can be very well displayed with short axis scans. Of course, we can change direction and study the tendons also along the major axis. I would like to remind that it is possible to move the wrist slightly in this way to study the first compartment of the extensors, and similarly as regards to the last compartment, the sixth.
L'ultimo compartimento, ossia il sesto compartimento, con questa scansione, diciamo, asse lungo che decorre.
With this scan, we can also follow the course of the sensor carpi ulnaris. The dorsal scans are also crucial to see the small ligament of the wrist, which is the scapholunate ligament. This ligament connects the navicular with the semilunate carpal bone. This is a dedicated scan in which we can clearly see this very thin ligament in the dorsal part of the scapholunate complex that runs right between the scaphoid to the left and the semilunate to the right. We can also perform dynamic maneuvers to establish any laxity or laceration of this ligament, which is very important for the stability of the wrist. Remember that more proximal scans will allow us to study another very important joint, the radio-ulnar distal joint. This joint can be studied with a dorsal, but also with a volar scan, to examine its osseous and articular components. This is a very specific scan that shows the distal epiphysis of the ulna, the distal epiphysis of the radius, and then the distal ulnar joint. We can now move to study and analyze the hand and its main components. We're going to study the flexor tendons of the fingers, the superficial and the deep one, at the level of the hand, doing very precise longitudinal scans to evaluate their aspect along the long axis of the tendons. This is an example of a scan dedicated to the superficial and deep flexors of the fingers, in this case, the third digit. We can see how the finger flexing and stretching clearly shows the movements of the two tendons along their tendon sheath. Immediately below, we recognize a very important articulation, the metacarpal phalangeal articulation. In this case, we see the metacarpal head, the base of the proximal phalanx of the fingers, the articular joint, and a small structure, similar to a meniscus, that represents the volar plate to stabilize the joints. We can clearly see, while doing this movement, that the volar plate has a weakly hyperechoic aspect. If we move the transducer distally, we may study some of the anatomical relationships between the tendons and the other articular components. We see how distally the tendons pass through various joints. Here we are at the level of the proximal interphalangeal, and, sliding even more, we recognize the distal interphalangeal joint. It is very important to study these tendons also on the short axis to establish some very important anatomical relationships. This scan of the finger displays the superficial and deep flexor tendons of the finger, along their extension up to their insertion. Let us remember that the deep flexor fits on the base of the distal phalanx, whereas the superficial flexor fits on the base of the proximal phalanx. As the last scan, we shall consider the tendinous extensor lamina on the dorsal side. Despite being very thin, they have a very complex anatomical appearance, as they have an expansion called the central lamina that fits, and here we see it very well, at the base of the proximal phalanx, and another expansion, more distally, that fits at the base of the distal phalanx. I would like to remind you that the superficial flexor tendon of the fingers is inserted at the base of the middle phalanx, while the deeper flexor tendon is inserted at the base of the distal phalanx. The lamina extensor tendon of the fingers is very thin, and it is hardly measurable if not in the presence of lesions. With this, we have now finished the scan of the hand. Thank you for your attention.